I am here from Baltimore, Maryland, representing the Johns Hopkins Hospital.
What?
I would like to thank you for coming to this extremely early session. There are many of you that I've harassed throughout the conference, so thank you for showing up to support me. Just a little bit about myself. I was born in Jamaica, raised in New Jersey, and got my teeth in emergency nursing in Baltimore, Maryland. I received my associate's degree at Oakwood University, a small private college in Huntsville, Alabama, my bachelor's at the New Jersey City University in New Jersey, and my master's from the University of Maryland. Where I received an MS, my focus was in health services, leadership, and management with a track in education. I received my MRS, that means I got married, to a Jamaican guy named Tony in Maryland, and I am the proud mom of 2 boys, Ian, age 6, and Nathan, age 3. As if this isn't crazy enough, we own a Jamaican restaurant in Baltimore. We're celebrating 5 years of business ownership, so that's pretty awesome. I am a podcast junkie, and I listen to a podcast called Happier by Gretchen Rubin. And every year they talk about making goals for the year. So in 2019, we needed to come up with 19 things that we wanted to accomplish. One of my goals, my personal goals, was to present at ENA. I applied, I'm here, my nerves are bad, but I'm happy. So enough about me, I am going to get right into why you're really here. Blowing Up Triage, one urban hospital's journey to improve the triage process. Disclosure, I am a consultant for Stochastic. Stochastic is the name of the company that developed our e-triage tool. These are the learning outcomes, and I'm going to read them because they're very important, and I hope that at the end of my talk, you are able to really learn from this presentation. So the goals are for you to be able to discuss some of the triage challenges faced in emergency departments across the country, evaluate the changes implemented in the triage process at a high-volume urban emergency department, and review the effectiveness of the interventions. Illustrate how partnering with other disciplines can have beneficial outcomes for nursing initiatives. Understand how using analytics for process improvement can be beneficial for staff and help with accountability for new initiatives. Analyze the need for change in your own institutions and be inspired to make steps towards that process. So this is a picture of a part of our hospital. This is the Sheikh Zayed Tower. The emergency department and lots of other units moved to this tower 7 years ago. It's absolutely gorgeous, but this is just a snapshot of a small part of the hospital. We are many blocks wide and many blocks long. Sometimes it seems like we take up half of the city itself. A little about the emergency department. We are a teaching hospital and a biomedical research facility of the Johns Hopkins School of Medicine, located in Baltimore, Maryland. In our emergency department last year, we had 67,000 visits, and we discharged 75% of those patients. So for those of you who've been around hospitals for a while, you realize that we only have 25% of our patients who get admitted, and so sometimes when we take a seat at the table, we don't seem like we have so much power because the majority of the admissions do not come from us. We are a 4-time designated magnet hospital, and for 2019, we are celebrating 130 years of nursing, and that's a big deal. This is a picture of our walk-in entrance. We have 2 entrances to our emergency department, the walk-in entrance pictured here, and about half a block over and half a block down is our AMBO entrance. So what that means is that the patients who come in by AMBO don't know what's going on up front, the people up front don't know what's going on in the back. And I know that we are unique because a lot of our patients come by ambulance and they think EMS means CAB, but I know you guys don't have that problem where you are. We end up offloading a lot of our AMBO patients because they really did not need to use the ambulance, and so they are given a great education as they're wheeled into the front to wait with everyone else. We have, I see we're not unique in that problem. We have 125 registered nurses. And, we do have some staff turnover. We know why. People come in to get us on their resumes. It's good for them to be there for about 3 years or so. We offer great tuition reimbursement. So we know that people come in and they don't always stay for a long time. And emergency nursing is hard, y'all. It's not for everyone. And I think it's great when someone comes in and they realize it's not for them and they keep it moving. That's pretty awesome. We have 30 clinical technicians and 18 certified nursing assistants. We have about 58 triage trained nurses. Our triage shifts are typically 8 to 12 hours, and there are 2 nurses assigned at triage. Because we are so busy, we have something that we call an upfront process. So some of our patients never get back to the main pod. They are cared for on the front end of our emergency department. And so we have a nurse who works with our screening providers, and that nurse does medication administration. Sometimes they do some follow-up in the waiting room. And so we call her the screening nurse. If the screening nurse is triage trained, the screening nurse jumps in to help triage if our patients are waiting greater than 15 minutes to get triage done. So now, there's always an interactive part of these things. So I am going to ask you to just go in little groups where you are, maybe 5, no more than 6 people. We're just gonna spend a few minutes, and I want you guys to talk about some challenges that you face now in your triage process, and if anyone has some ideas on how to fix those challenges, now would be a great time to offer them. I know it's early, not everyone's a morning person, but I worked really hard on this, so do it for me. Thank you, just 2 minutes.
Of course not. No, I'm sure not. I love your presentation yesterday. Bus unlocked. Tracy's watching. Can you see her? I should join a group. Good.
I've been in like T2, so not T1 but T2, so I'll do like maybe some vitals and stuff.
Just like this is that's, I would say, one of our biggest challenges.
Right.
To get to this point, of course, we had something that's early applications, it's bad. You have so many orders, of course, process, and now
You know, unless it's like crazy busy, we have the direct triage committee and things like that. And or we might get like the quick questions between you get like the math and we'll just get not like the prime. I'm still like what, a little over a year at this facility. So northwest is, so we're like one of the
Caroline's got
Funny.
me.
It sounded like we were at the same spot last night. And we were like looking around
What?
for you and Kieran.
I didn't see you on the side that you were over.
I feel like there's 2 sides. Like maybe you
Yeah, I
guys
saw
were
one
on.
that
Yeah.
there was like a platform on the side where the hotel is.
Okay. It was just a hill that we were on.
Okay, you were
Did you
there,
see
like near
anything?
Yeti.
Yeah. Yeah.
No, we
in
left.
that
We
direction.
left. We didn't see it. Did you?
Yeah. At the
Like-
end, it was like, almost completely dark. But we kind of were walking, and then at the end of the bridge, there was like a light that was shining over the bridge, and there were tons of bats there, and they were flying around, but you couldn't see it unless.
I
it was
only
shining.
expected 20 people to be here this morning because the session was so early. and I didn't expect this spirited conversation about triage problems. So you guys have blown my mind and exceeded all my expectations. So I'm going to continue with our talk. Hopefully you've made some connections in this short period of time, and you can actually solicit great feedback from the people that you've met to improve some of the processes that you have in your emergency department. So I'm going to talk about some ED challenges in the United States. We know that ED overcrowding is a national problem. It has patient safety concerns. It's associated with poor quality of care, negative clinical outcomes. What ends up happening to some of our patients is they come to the emergency department, they see a waiting room that looks like my audience, and they make a decision. I'm not that sick. I'm going to go home. Unfortunately, for some of them, they really are sick. And so they go home, they have some negative outcomes because we were just so busy, so overcrowded that they didn't access care. The problem with overcrowding is not a new one. As far back as 20 years ago, the literature showed that we had a problem with ED overcrowding. It showed the negative implications that are actually coming to fruition. And it isn't surprising that we're that busy. In 2016, the CDC reported 145.6 million emergency department visits. That's a lot of visits, y'all. A lot of people. And you know, in emergency nursing, we sometimes, we sometimes say, that's not even an emergency. Why did they come? Well, really, guys, if all 4 of your patients in the ER were level 1 true emergencies, you would not be able to manage your assignment. So sometimes you better thank God for the belly pain that you have to wait for some stuff to happen, because it gives you time to focus on the person who's really sick and who you really need to give all those resources to. And we also have to sometimes redefine the word emergency. If I do not have insurance, I must work. If I don't work, I don't get paid, and my leg is injured, you better believe that's an emergency for me. Because that might mean that I can't pay my rent, my kids can't eat, and no one can go to school. So we sometimes just need to be a little bit more realistic about what an emergency is for a particular person. Sometimes people come to the emergency department for various reasons, right? We have a subset who they just love us and we're going to see them every single day that the Lord sends, right? Those are the ones that when we don't see them for 2 days, we get worried because we wonder if, they've gone to the other side. And then we have some people who try to do the right thing. They're not feeling well, they call their primary care physician, and what does that person say? Go to the ER. Or they actually get into the primary care physician and they say, you know what I'm going to do? So the next time the person has that problem, why go to the doctor? Cut out the middleman, go right to the ER. Our patients complain about our wait time, but in reality, if they needed to get those labs, the x-ray, the CAT scan, and sometimes even the MRI, it would take months to do that. They know they could come to the ED and sometimes get all those services the same day. So some of our customers are pretty savvy. They know what they're doing when they come. We also have people who are uninsured or underinsured, and so they're going to come to see us as well. So what happens with overcrowding? When the house is full, and by the house I mean the main hospital, when the house is full and they have not done a good job with getting those discharge orders in and getting those patients out, we suffer in the emergency department. Why? We have that bottleneck. The patients are laying in the beds, the patients who need to be admitted. We can't send them anywhere, and so the patients on the front end of the emergency department, those patients that need those beds, they have nowhere to go. So they're sitting in the emergency waiting room, and our waiting room is not comfortable, and they're not feeling well, and it leads to a lot of anger and frustration for these patients. It impacts triage because when we have a large surge of patients who come in, we now have patients who are waiting longer and longer to get to that triage nurse in order for that nurse to sort them and figure out what is really happening and what resources they need. So I'm going to talk about some challenges that we have in our emergency department. Now I'm sharing some embarrassing stuff. I don't want you guys to tell anybody what I told you, okay? We had a problem with our long door to triage times, long door to EKG times, and poor patient differentiation. And I'll spend some time talking about each topic. So problem number one, door to triage. So we know triage is usually the first formal medical encounter that a patient has when they come to the emergency department. What we found in our previous process is that we weren't really serving the patients well. A patient would come in, they would get the quick reg done by our registration folks. We call them ESCs, Emergency Service Coordinator. They would get the quick reg done, we tell them to go take a seat. When the triage nurse was ready, willing, and able, she would go and get the patient, bring them, get them triaged. When she was done, she would send them back to the waiting room to have a seat. When the screening provider was ready, we'd move the patient into the screening room. After they were screened, we would send them back to the waiting room to take a seat. When the clinical technicians were ready, willing, and able, they would bring them over to get the labs done. After that, we'd send them back to the waiting room to take a seat. When you're not feeling well, nobody wants to be a ping pong, okay? There was a time when the whole Disney process of keeping them moving was big in emergency nursing. It doesn't work when you don't feel well. We need to create a process that's more streamlined for the patient and doesn't have them going back and forth when they're here because they have an emergency. So our goal was to have all patients start the triage process within 10 minutes of arrival. We measure this time from when quick registration ends until the nurse hits the order button in triage. Now, our average patients were waiting 7 minutes to be in the triage process. I know it's early, and I know you know math, and I know that 10 minus 7 is 3, so we were under our goal, but what we saw was that that time kept creeping up. And what we needed to do was stop it before it got to the actual 10 minutes and end up at 20 minutes, right? Preventative medicine. And you know, if the average time was 7 minutes, we had some people who always had patients waiting 10 and 12 and 13 minutes. And they had no good reason for keeping those patients waiting. So these are the action items, and I apologize that the slide is so small that you can't really see it clearly, but we coordinated with our registration friends. And what we said was, when you are done, we have 2 triage nurses, remember. When you are done with quick reg, if the triage nurse has an empty chair, send that patient directly to that chair. Oh, we got a lot of pushback from nursing. What are some of the reasons you think, some of the excuses we got? I'm not ready, that was one. Now sometimes no one more critical was in, because if someone was more critical, then that's understandable. We heard, I wanted to finish up what I was doing, even if what you were doing was browsing the internet. We heard, I wanted to review the chart before the patient came over. Well, that's not what triage is for, right? Triage is for sorting, not for reviewing charts. Oh, they come here all the time. Every visit is a new visit and should be treated as such. And so we took a hard stance on this, that if the chair was empty, a butt should be in it. And patients weren't upset if you said to them, hey, I'm just finishing something up on the last patient, I'll be right with you. No one complained about that. The way our computer is placed, the patient who's sitting cannot see the computer. So there's no excuse about privacy. Unless they can understand clicking and no one can, they wouldn't know what you're typing, okay? We designated chairs for patients who were waiting to be triaged, 4 chairs. We realized quickly that that was not a good idea for us. The reason it wasn't a good idea is because our waiting room is small and you know, pretty packed. And so if you come in with your family members because you need to be seen and you see 4 empty chairs, what are you gonna do? You're gonna go to the 4 empty chairs. It became a little bit of an unpleasant conversation to keep saying, oh, excuse me, can you just please leave those only empty chairs in the emergency department while we wait for people to come in and take them? So we decided to scrap that because it wasn't working. It wasn't worth the argument with the patients. We encouraged our nurses to hit the order start button as soon as the patient sat in the chair. Because we had some nurses who were doing the whole process, but not clicking that button. And you know we're in a data-driven industry. We need the data to show that we're really doing what we're supposed to do. So we encourage people to give themselves credit for what they were getting done. We initiated a police icon in Epic. On our Epic board, if someone comes in by ambulance, there's a little ambulance icon that pops up. And remember, our triage nurses are up front. So when an ambulance comes, they have to walk to the back to do the triage. When we see the ambulance icon, we know to run back. But we weren't seeing that for people who are coming in by the police. And the police use the same entrance that EMS does. And so we got the police icon up. So now you had a visual cue that there was someone in the back and we needed to get to that patient. And we also asked our ESC, who did the quick reg for the ambo patients, to give the triage nurse a call, just to say, hey, someone's here with the police, so that we could meet them and get the triage done. So out of the 5 initiatives, only 1 was ineffective. We scrapped that, we continue to do the other 4. We gave out report cards. I'll tell you something. For my associate's degree, I wasn't a stellar student. I was very smart in high school, and I thought I could go in with my smarts for my associates. And I quickly realized that nursing school was no joke. By the time I went for my bachelor's, I was much more serious and much more studious. When I got to my master's, if it was anything but an A, I was having a fit. So report cards are important to me, and it turns out they're important to a lot of nurses where I work. We gave out report cards about individual door to triage time. Y'all, life-changing. People didn't believe that they actually contributed to the problem. And now here you have a sheet of paper telling you that on average, you take 10 minutes before you start triaging a patient. Changed everything. Immediately, people sprang into action, and it was awesome. So we give report cards for lots of measures where we work, and no one sees your report card but you and the informatics person and the team. So, people kind of hold it close to the vest, but they make great improvements. So this is my report card. The numbers in the blue box, those are the amount of patients that I triage, and the number right underneath is the date. So most times I'm at 100% with getting patients done, triage in less than 10 minutes. But if you look at the bottom, there was a day that I dipped down to like 96%. And for the ambulance or police folks, I was 100%. It's fine if you dip down less than 100%, right? Because there are reasons that can happen. If I have a complicated patient and I need to figure out what has to happen, I'm not sitting there going, my report card is going to get messed up if I don't do this. I am going to care for the patient. If we have a surge, if we have to run and get someone out of the bathroom who's, an overdose, like things are happening in the emergency department. So this isn't a punitive measure. It is just something to allow you to realize that you contribute to the problem. Any leaders in the room ever have any meetings that you're discussing a problem and everyone says, well, I do it the right way. The report card lets you know you haven't really been doing it the right way. It helps with accountability. So this is the arrival to triage data. And on the bottom, we have the month and the year. So it starts off at August of 2015. And you see that we were high up at about 8. And then the most recent numbers that I have, May of 2019, we are down to 3.9 minutes for the door to triage time. And that is absolutely awesome. So since implementation, we now have an average door to triage time of 4.1 minutes. Report cards were given initially, and they were eye-opening. We send data a lot to our nurses just to let them know how we're doing. Not the individual report cards unless they ask for them specifically. And we have had nurses ask for this report and we give it to them. We are fortunate enough to have an informatics nurse who loves what she does, and so she's always helpful in these cases. And the report is right from Epic, so anyone can do this. The second problem was our door to EKG time. So prior to implementation, the mean EKG time for walk-in patients presenting with chest pain measured over a 3-month period was 21 minutes. Can you guys tell me the goal for the door to EKG time? 10 minutes. Everybody knows that. We knew it too. We tried so many things to fix this, and it just didn't seem to work. We talked about the importance of it. We stressed the importance of it. I don't think a meeting was had when we didn't discuss how we needed to improve these times. And for some reason, you know, we would make some gains, but we would always fall back to this long wait. So for our interventions, we decided to assign one of our CNAs to the role of EKG CNA. We gave them a designated phone, and for their shift, that is what they were responsible for. We partnered again with our registration colleagues, and we said to them, anyone who comes in with a complaint of chest pain should get a red heart, and I'll show you the red heart in a minute, and go directly to the EKG booth if it's empty, or to a designated chair to wait for the EKGs to be done. What the red heart did was it gave a visual cue to anyone walking by that this patient was waiting for an EKG to be done. And we only gave those red hearts to people who needed that 10-minute EKG. If they saw the nurse and the nurse decided they needed an EKG, or if they were screened by the provider and the provider wanted an EKG, those folks didn't have the red hearts. But the red hearts indicated that we needed to get this done quickly. Now, we talked about other chief complaints for our registration folks, and we went back and forth with this for a little bit. What about chest pressure? What about angina? What about my heart doesn't feel right? We just decided to keep it simple. They are not medical personnel. Let's not have them have to go through a whole lot of thinking to get this done. Let's focus on chest pain. Since we have a great door to triage time now, when that patient quickly goes to the triage nurse, if they give the triage nurse some information, the triage nurse will stop triage and get that EKG done. This is our red heart. Red paper, Microsoft Word, laminator, scissors. Okay, this is what we did. And this was suggested by my assistant director for her Lean Sigma project. She realized that something needed to be done, and this is what we did. So in preparation for this talk, she said to me, Sophia, you know I can make you some new hearts. I said, that's okay. I want the people to see what we use now. This is what we use. How simple is this, right? A great intervention doesn't have to be expensive. It doesn't have to be the highest level thinking. It can be something practical that can really improve your numbers. So these are the action items. Give the red heart to patients who present with chest pain. Take them over to the designated booth or the chair. Have the EKG performed within 10 minutes. Do triage after that EKG is done. Once again, a hard data sheet for you to see. But what we ended up seeing was that for our patients who walked in, down at the very end, where it says 201903, that's March of 2019, our average time there was 8.8 minutes to get that EKG done. Now, up top, we have all patients in blue, and it says 12.9. Because the reality is that we're still having a hard time with our patients who come in by ambulance. I told you that we offload a fair amount of our patients who come in by AMBO, and so we still need to work on that process of getting those EKGs done for them. A lot of our EMS folks are able to transmit the EKGs. For some reason, they don't always do it. So when they don't transmit those EKGs, and if the patient isn't someone who we can easily offload, we need to find a space to get that EKG done. We don't have, the EKG booths are in a small area. We can't get the EMS stretcher over there. So we have to find an empty room. We don't have empty rooms, y'all. So we have to come up with creative thinking in order to get those EKGs done. So that's a work in process, and we know that we need to fine-tune a process for that. So I might need some suggestions from you guys when this is done, if you've been successful with that. So this initiative began in November of 2015 and was ongoing until June of 2016. Post-implementation, the mean EKG time for walk-in patients was 10.6 minutes. We were able to cut that number down by half. This was a big deal for us and continues to be something that we monitor, we send email about, we send data. We still let everyone know the importance of getting this EKG done within 10 minutes. Lastly, initiating e-triage. How many of you guys use ESI? Just about everyone, right? ESI is the most commonly used triage system not only in the United States, but across the world. What we found with ESI is that we were having some issues with